I profusely thank Dr. G.V.K. sir for one more opportunity. And on a topic, I was repeatedly told in the last few minutes that it's going on time, but I have been given two topics. I spoke to G.V.K. sir and he said, anyway, you try to squeeze in. Bone health itself can be a 1 hour session. Anemia and diabetes can be another big session. And both are given only 15 to 20 minutes time. I'll try my best to squeeze as much as possible and give a quick review or bird's eye view of these problems. And I thank Professor Das sir. He has nicely mentioned that some of these simple things which we are taught from our first year MBBS days are sometimes overlooked. And that will be actually the introduction for anemia. Because for this talk, last 1 week in our hospital with our PGs, I was repeatedly looking at how many of them had hemoglobin levels, etc. And almost 50% of them have WHO definition of anemia in the standard clinic, which means women less than 11 and men less than 12 in non-pregnant state. So you can imagine the burden is too much, and those slides will be boring. And both anemia will have an impact on diabetes, not only the pathophysiology of the disorder, as well as the complications, response to medications, causing complications. The reverse is also true, which means diabetes also causes anemia in various ways. Most common cause of anemia in a diabetic, suppose you are following up in a typical clinic, a general clinic of diabetes. If a 40, 50-year-old patient who comes with diabetes, male or female, he has anemia less than 10, first rule out CKD. This is the most important. Immediately don't just prescribe. Many times creatinine is missed. Today packages have come. We are from the era where packages are not, the tests are not done, or sometimes it's overlooked. So if you rule out the CKD part, then comes all other discussions on what are the various ways diabetes and anemia interact with each other. And since type 1 diabetes may not be the cup of tea for many people here, especially in children, but it is worth remembering that this is one unique condition among the subtypes of diabetes where the causes of anemia are very unique, unlike the usual nutritional, iron deficiency, blood loss, etc. in a typical adult practice. So autoimmune etiology of anemia, in addition to nutritional anemia, is the most important cause of anemia in type 1 diabetes, both in children, adolescents, and even when you are following up adults. Had this been North India or West India, celiac disease is very common. In South India, fortunately, it is less. This exemplifies again our understanding of how nature, food, the topic theme itself is food for thought. So the food and diseases also interact. In the rice eating belt of India, generally celiac disease fortunately is less common. There are 3-4 South Indian papers from Vaidehi Medical Institute, St. John's and other places. It is less than 3% or 5% in type 1 diabetes populations in South India, but it is almost 30-40% in the North India. So you can imagine any patient with anemia in a type 1 diabetes, celiac will be screened every year. If you look at the guidelines of follow-up of type 1, celiac will be there. However, in our setup, in adults practice, B12 deficiency due to malabsorption related to pernicious anemia and rarely hemolytic anemia, or the hypothyroidism, which is again is almost 2/3 of your type 1 will be hypothyroid, especially on follow-up if they are autoimmune etiology. So this is type 1, so we'll set aside. Type 2, this whole slide is taken up from a beautiful review by Dr. Rakesh Sahai and Sanjay Kalra, published in one of the standard journals, a review of anemia and diabetes. You can see everything is there. Today all these words will be repeated in several of our lectures here, and some of them are very important. Every aspect of diabetes and its vascular complications in one way or the other influences the development and progression of both its own complication and anemia. Especially one of the commonest drugs we all use is metformin. Metformin and B12 deficiency is repeatedly talked about. Even in the US guidelines, now they are saying that routine B12 supplementation may be indicated in metformin. And interestingly, few things like DPP4, SGLT2, which I'll touch upon in the next few minutes. So, in addition to this, per se anemia can influence your way of seeing HbA1c itself, which is a very important tool in our monitoring of diabetes. Every time when you see very low hemoglobin, please check whether your HbA1c is reliable. iron deficiency, the prolongation of RBC can increase HbA1c. I'll come to some interesting points epidemiologically that in India we have this dual or triple problems of anemia, diabetes, obesity, everything occurring in the same population. So iron deficiency anemia, you can overestimate diabetes if you go by HbA1c as the definition of diabetes. B12 deficiency, folate and all I mentioned already. And there are conditions of hemoglobinopathy with the world becoming smaller and too much of medical travel. We have many Bengali patients coming in many hospitals in Chennai. We have so many hemoglobinopathies picked up daily. HbE very common, even HbS 1 or 2 we picked up, and rare hemoglobinopathies. So whenever there is a discrepancy between your fasting postprandial reports versus HbA1c, and if the CBC is not showing any major abnormality, think of a hemoglobinopathy. A low hemoglobin, thalassemia is not rare in our population also. So always look into other causes of, so we cannot be very happy seeing a HbA1c of 7.1 in a long-standing diabetic, but the fasting is 180 and PP is 280. There is some, so these are all small clues which will give us when to suspect these causes of anemia, as well as the etiology of anemia, which will help you in monitoring. So what do you do in those kind of hemoglobinopathies? That is why technology is helping us. Either you should go for CGM, which is now available, or 1,5-anhydroglucitol is one more marker, but these are all not standardized. Fructosamine, which is otherwise glycosylated albumin, can be used, but all these need standardization in a given setup. The easiest way is to frequently monitor SMBGs, which is the easiest in any setting, or use CGMS at least once in 3 months to know that they are under good control. Otherwise, hemoglobinopathy, you can't say the HbA1c cannot be used, so I won't monitor diabetes. So what does anemia do to the complications? It's very well known that CKD causes anemia, but it is worthwhile remembering for today, from today, that anemia also complicates CKD. So it's, see, one of the basic diabetes defining problem is the microangiopathy. We all know that, endothelial dysfunction. And at some point, the microangiopathy, especially at the local level, causes hypoxia or decreased perfusion. Anemia also does the same. So wherever there is microangiopathy complication, it will be worsened by anemia, and kidney is not an exception. And you can imagine the number of studies showing, both animal and human studies, due to altered sympathetic activity, how the local oxidative stress in the peritubular and other areas causes both the RAS pathway dysfunction as well as local functional erythropoietin deficiency, leading to more worsening of the pathophysiological process, leading to DKD. This is diabetic kidney disease. And needless to say that when these 2-3 unholy nexus between anemia and diabetes and kidney disease go together, worsening of CVD, stroke and hospitalization, they all will happen. Retinopathy, I remember my DM days, one of my seniors did a beautiful study on how correction of anemia actually improves retinopathy. Correction of dyslipidemia improves retinopathy. Good dose of statin, the hard exudates will come down. These are all proven facts. If you listen to ophthalmological lectures, it's well proven fact. Anybody with retinopathy, please, lipids even if normal, if they have hard exudates, they are an indication for good dose of statin. Same way, anemia, same hypoxia, same. So you should correct anemia to improve retinopathy. And multiple pathophysiological processes are there, and all these culminate the danger fellow, which is cardiovascular disease. And anemia is a well-known risk factor, both precipitating heart failure as well as worsening your CAD. And the same ischemic problem of anemia can be a risk factor in worsening your wound healing in a case of diabetic foot ulcer. So these are all easily understandable things. Only thing is extra attention and extra few minutes of addressing these issues to be done in our day-to-day practice. A few seconds on medications and anemia which are used in diabetes. Metformin I already mentioned. It is interesting to note that metformin actually, through some calcium dependent mechanism, actually reduces the B12 absorption, and there are studies to show that even calcium supplementation can improve B12 absorption in a case of metformin. There are some companies which are coming with metformin and B12 together also. I am sure you must be knowing some of the brands. And here I would like to make a provoking statement. It is unfortunate that India has the dubious distinction of the maximum methylcobalamin prescriptions in the world. Methylcobalamin need not be given for B12 deficiency. Cyanocobalamin is simple, plain B12, cheapest, you give it the same response. There is no proof to say that conversion of cobalamin to methylcobalamin is defective in diabetes. But for various commercial reasons, we know that how methylcobalamin is the only brand now available. Any multivitamin has methylcobalamin, not cyanocobalamin. Can anybody name here how many cyanocobalamin preparations we know? A lot of senior people are here. They will be knowing in the past. Today, many of them are converted to methylcobalamin. So this, please remember. And this universal omeprazolization of the whole world is happening now. So this PPI use is rampant. And this PPI is one common link between two of my talks. Both bone health is affected, anemia is also worsened, B12 deficiency, iron absorption, everything affected, achlorhydria, hypochlorhydria, calcium absorption, you name it, there is a problem. But unfortunately, rampant, prolonged use of PPIs is going to have a detrimental effect. But in an academic forum like this, I can add a nice twist to this story by saying that PPI use can reduce diabetes, it has a GLP-1 secreting effect, etc. These are all academic things which can take us away from the main point. The main point is do not overuse PPI for a long period. And there are interesting points like AC and ARB also through their effect on the RAS system and through that on the EPO, that is erythropoietin, can have some effect on erythropoiesis, but they have tremendous beneficial effects on both kidney and CVD reduction, so we have to continue them. So one more point is, interestingly in this whole discussion, DPP-4 inhibitors and SGLT2 inhibitors, at least on some small scale studies, have shown that they have some improvement in anemia, not in worsening the anemia through their effect on erythropoietin. But none of these are used for that particular purpose, but in a given case, in an academic forum, it is worth remembering. And glutazones, due to their dilutional effect and replacing the bone marrow into fat, will have an effect on anemia. So in bariatric surgery, we all know how those things occur. So I have already mentioned iron overload, hemochromatosis causes anemia because there is iron deficiency. There is one new term being discussed with this dysmetabolic iron overload syndrome. That means in insulin resistance, obesity, NAFLD, there is an extra iron absorption, unknown reasons happening, loading the pancreas. Some extra iron causes oxidative stress and distress of the beta cell, leading to worsening of the pathophysiological mechanisms of diabetes. And in the same note, you can imagine how much complicated will be in a gestational diabetic patients. Overzealous use of iron in gestational diabetic patients, they have clearly shown by many observational studies, there is a link between extra iron dose and anemia. But here is the problem in India. I cannot say this in the same tone in an OG forum, where already anemia is a big problem in our pregnant patients. I can't say you give iron, will it cause GDM? No. Be moderate. The alavukku minjinal amrutham nanja is coming everywhere in our practice, and iron is also not an exception, and already there is an OG practice that they don't give iron extra in the first trimester for various other teratological reasons. But here they give, in GDM, we have to be careful not to treat overzealously. So what are the take-home points from anemia point of view? This is an often overlooked problem. HB less than 10, be very cautious, look carefully into it, find out the cause, treat it, don't label it as just diabetes related, just write one more multivitamin and send. See to it that it is corrected. So next 5 minutes only I'll take on bone health. I'll quickly rush through like a video here. We have another problem of bone health in diabetes. These are all skeletal problems which we all see day in and day out, but focus will be on only osteoporosis over the next 5 minutes. India is an aging population. We all know longevity of our diabetic patients are much more than non-diabetic people. And we are going to be having dubious distinction. Already we have crossed China last few days in population, aging population increasing, diabetic population increasing. Across states, it's not just Kerala alone anymore. Everybody is having 70 plus. And osteoporosis prevalence in diabetes, very high. Because both are common chronic conditions. You have a 60 plus, 70 plus people, you will have diabetes and anemia. Every fracture patient we are seeing in our hospital has some form of diabetes also. And interesting, these are all comparisons. Type 1 diabetes, very poor bone health in the long run if they are not controlled well. Comparing with type 2 and versus rheumatoid and SLE, they have shown that diabetes fares like rheumatoid. So a patient having rheumatoid for a long time and a patient having diabetes have somewhat equivalent detrimental effect on the bone health. And this is being shown. That's why I will come to the practice point on this. What is the use of knowing this? The important point in this slide is diabetic patients fracture at a higher BMD. So using the already DEXA scan is an underused or an abused, both end. Abused in master health checkup, underused in needy patients. This is happening in routine our practice. Bone in diabetes is quality is affected, quantity is not that much affected. So they all fracture at a higher BMD. You cannot diagnose osteoporosis and fracture risk by BMD alone. So what have they suggested? You either use FRAX score, which I will tell you. You take diabetes as rheumatoid equivalent. I was remembering Hafner when I was studying this, because he only said that diabetes is cardiac disease equivalent. That was the early 2000s. Every lecture like this, somebody will say Hafner data, diabetes equivalent to CAD. Similarly, you say diabetes equivalent to rheumatoid arthritis with respect to bone health. And use in your FRAX score, instead of rheumatoid, you put diabetes. If your patient has diabetes, put rheumatoid plus. Then you will get a score which will tell you the real thing. This is the simplest practice point, the only treatment. But I will not bore you all with all these complex nature reviews on how osteoporosis, pathophysiology, in a complex manner. And so many anti-diabetic medications have some detrimental effect. The most important is glitazone. Please, in your practice, in a postmenopausal lady at least, do not use glitazones if they have a bone health problem or fracture. Please, this is a very, very serious issue. This will cause, there is no doubt here, sugar control nalla varudhu, vendam. அவங்களுக்கு வேண்டாம், அவங்க ஃப்ராக்சரே அப்புறம் வேற எங்கேயும் மண்டை போடுவாங்க. And we are often seeing all these problems. So do not use glitazones, at least in elderly people with fracture risk which are higher. Secondly, of course, you should control hypoglycemia, you should control the nervous problem. Fall risk also should be assessed here. It's not just the bone quality alone in these patients. SGLT2, it's controversial, but in a given patient, take your own call. There are incidents of fracture, canagliflozin study, they passed off saying that it's only the metatarsal fractures, but in a given patient, be careful. So the safest agents are the other agents which we all know very well. So we need to think beyond BMD when assessing bone health in a diabetic patient. Just I ordered DEXA, T-score is good, so diabetes lo onnu illa, appadi panna mudiyadhu. You have to use what is called FRAX score, the quality is affected, and the same advanced glycation end products, all these are affected. So the quality is affected than the quantity. So how do I assess? There are certain modifications which can be done within the available framework of our DEXA scan. What is something called trabecular bone score, which is not available routinely. It's just a software. If you add another 7 lakh or 8 lakhs of that software, you can assess all your this kind of a pictorial diagram you will get, and this trabecular bone score is a very useful score. If available, it can be used. Otherwise, as I said, use the and always all your diabetic patients, if you suspect bone health, get an X-ray at least, if not this VFA and other things, any spinal fracture to be treated. The only message from bone health diagnosis point of view, in a diabetic patient, use FRAX score and use rheumatoid arthritis as your equivalent. You put yes there. Here I have put no here. This is Indian score, by the way. This is now reasonably standardized. It gives a very nice idea at a primary care level whether your patient is at extra risk for bone health. Use diabetes as rheumatoid arthritis equivalent. And what is the treatment? Always good bone, vitamin D and calcium. I cannot say more than this, and I'll skip some of these slides in view of time constraints. Bone health diagnosis will be a problem. BMD will not be low in diabetic patients. Secondly, vitamin D has multiple pleiotropic benefits. Do not use vitamin D do not use vitamin D just because for diabetes will improve. No, bone health will definitely improve. Supplement calcium. If in the calcium PPA use, absorption will be poor, calcium carbonate won't work, you have to use then citrate. All these are discussions beyond the limit of this 20 minutes, but just to tell you that supplement calcium and vitamin D adequately. Do not just like that reflexly prescribe an agent which is anti-osteoporotic. Bisphosphonate kuduthalla. That's not the answer. Preventing fall, adequately treating vitamin D, calcium, checklist of all the drugs so that you modify the drugs which are detrimental to bone is the most important step you can do. I stop here and thank you very much for your kind attention.